So this page describes a new clinical test that's been developed based on biomechanics for the hip abductors and external rotators. So here we have the reference test or old test, which is a sideline hip abduction, and the trunk strapped, and there's a movable arm from an isokinetic device to measure the abduction torque. Here we have the new test to the right, where the person is standing. Their trunk position is 30 degrees of flexion, their knee position is 50 degrees of flexion, and they have a strap with a transducer in the middle that is going to measure their ability to push their knees apart. It's connected here through a wire into a computer screen we see here on the right, which then gives the person feedback in terms of how much torque output or their force output they're producing in this strap. So the new test has the advantages of it's functional because it's weight bearing. It's also combining abduction with external rotation, which is connected to therapeutically to us trying to facilitate patients moving out of this knee heart attack position or the position that causes knee injuries via the hip. So this hip adduction and internal rotation position. So now we have two graphs of output. On this figure 4, what we see is the non-weight bearing hip abduction test. So that's the old test, and then we have that compared to the new weight bearing hip abduction external rotation test. And we can see that they're correlated. In other words, that if you are stronger in sideline, you're also stronger in weight bearing. But we also see that the correlation is not exact, and so there's some important differences between testing somebody in a sideline position as compared to testing somebody in a standing weight-bearing position. So then we could say, what's the validity of this test? In asking that, we're asking about the meaning of the test. And so we're trying to figure out, in terms of the new test, what muscles in particular are being tested. So if somebody's weak in the standing weight-bearing abduction and external rotation test, what muscles are implicated in that weakness? And so we find here in figure 3 is EMG data from people performing the test, and in particular we have 3 muscles, the glute maximus, glute medius, and tensor fasciae lata, shown relative to their maximum voluntary contraction or their MVIC on the y-axis. And we can see that the most active muscle, nearly 100% activation according to its reference contraction, is the glute maximus, and then around 80% is the glute medius, and then at a much lower percentage is the tensor fasciae lata. So it's interesting that the glute max is the highest one, and it implicates this muscle in control of hip adduction, external rotation, and then also coupled with the glute medius. But because the tensor fasciae lata, although it's a hip abductor, it's also an internal rotator. And so likely because of the internal rotation, the external rotation component that's required of the test, there's much less activation of the TFL. So in summary, this is a valid new test. That's one option to quantify muscle control at the hip in patients with specific internal rotation and abduction weakness.